Hello, this is Dr. Ashley Parks, and I'm here to share with you all today a little bit about systems thinking, one of our first really content-related elements in Module 1 of our course together. As far as our module objectives, today we'll be talking about explaining the concept of systems thinking, specifically looking at a system and a map and understanding and identifying the components of that system, and then talking about the various system boundaries, components, and relationships within our healthcare system. And this is just the first conversation in this area. So we will be looking at different types of healthcare organizations, different types of interrelationships and components. But hopefully this will help us lay the groundwork. One thing that I want to make sure you all are aware of is the 200 Years of Medicine video that is posted that I am asking you all to review to inform one of your first assignments. This video is really crucial because not only does it give you a great idea of how our medicine, our healthcare system, but our practice of medicine in the United States has grown and changed, but it also will help inform how you understand and reflect on that system and how you incorporate your own knowledge, your own lived experience into that first journal entry assignment. So this is the video that's assigned for that journal entry assignment. And it really shows us how medicine offers us hope, but it does cost money. It does progress a little bit every day, every year. And healthcare is a very diverse, very dynamic movement-based industry with many, many participants, many, many different parties involved. Now, one of the concepts that we'll talk about later on in the semester that will arise as one of your short write-ups, not your first, but one of them, is the idea of dealing with nurse shortages. And I cannot think of a better example for systems thinking than all of the various issues, we can say causes, but really various interrelated factors that can lead to nursing shortages. And there's some notable examples. 2021 was a tough year for nursing. 2022 was as well, but specifically there were several pieces of news that came out in 2021 looking at nursing shortages in the ICU, specifically in the West. So looking at Las Vegas, Phoenix, Arizona, during COVID. And then when we think about the history of this, the Atlantic, there's a very interesting article back in 2016 about how we're running out of nurses. And I will be sharing in another lecture a little bit about how that fuels immigration and individuals who move to different countries with certain technical and clinical skills. But this is an issue we've been talking about for many years. I started working in healthcare over 20 years ago, and we have been talking about this for more than 20 years. So it's just a good example of a question that we'll come back to that definitely involves systems thinking. And so when we ask what a system is, for the purposes of our course, and for most general health services delivery courses, we think of a system as a group of interactive and independent parts, individual organizations, individual groups, the federal government, different providers. And then we think about the boundaries that distinguish those organizations. And those boundaries may meet, right? Those organizations may come together. Thinking about organizations with distinct boundaries and distinct relationships helps us think about processes, those interactions that happen, and how our mission, our goals as healthcare providers and organizations and health services administrators involve us working together and therefore interacting, right? And that can get really interesting when our mission as an organization calls us to work with other groups or to provide care and integrate in different ways. When we look at systems, again, systems are when we have multiple organizations, groups, individuals, entities, if you will, that have different parts to themselves, but also operate as parts of a greater system, a greater ecosystem, if you will. They all have boundaries, but they have some sort of thread that ties them together, such as the reimbursement system that we see in healthcare that has health plans interacting with hospitals, interacting with outpatient centers. And I think it's really important that we take this moment to think about how we can identify those large health systems. For example, there are integrated delivery systems all over the United States. I'm from California and we have Kaiser there. But then out here in North Carolina, we hear about Atrium, we hear about Novant, these big health systems that are in and of themselves a system, but are part of the bigger United States and local healthcare system. So the ability to understand that sometimes smaller systems are nested within larger systems, and they have all sorts of different relationships. When we think about systems, we often think about interactions. And then that leads us to a discussion regarding something called feedback loops. How we all interact and certain types of feedback causes changes or repetition in behavior. For example, your HVAC system at home, your thermostat, when it gets too cold, if you have the heater set, the heater will automatically kick on, hopefully, if it hits a certain temperature. Let's say you don't like it below 65 degrees in the winter. When it goes down to 65 degrees, the HVAC system will turn on. That's a simple feedback loop. The difficult part about the health system is it's not that simple. We have multiple payers, so health insurance companies, we have multiple providers receiving payment. We have different rules and rationale and policies around how we set prices and how expensive things are, how much they cost. And normally that is coordinated through the use of contracts. And so when we think about feedback loops, what happens if a provider's quality goes down? How immediately are there consequences in the health system? Either consequences from patients and families who are upset, consequences from health systems who don't want to contract with them anymore, right? These are much more complex systems, even though there still will be feedback and interaction, it's different. Now, we often refer to open versus closed systems when we talk about systems thinking. An open system is one that's very sensitive to the environment. It can adapt to the environment and environmental factors impact it. Our health system is an open system. The healthcare policy landscape, rules and regulations, the environment, COVID, all these different factors impact our health system. Closed systems generally are short-lived, where they very quickly become irrelevant if they don't adapt to the needs of customers, the feedback loops required in order to grow and change. For example, the H1N1 vaccine decision support system. This is an example of a very specific system, right, that was designed to support the use and manufacture of the H1N1 vaccine. It was designed to be temporary. If we want systems to be interactive, to be resilient, we have to design systems that can change and adapt, that can serve maybe more than one pandemic. In this case, the vaccine decision support system incorporated a lot of different metrics in order to respond to needs. And that's important, that we have an open system that's responsive. The only way we can survive is if we adapt and if we can maintain, and just like from a biological perspective, if we can as organizations, systems, and individuals maintain some sort of homeostasis, some sort of, are we okay? Are we functioning? And we do that through adaptation. Now, there's a lot of different approaches to systems thinking, but it's important that when you do systems thinking, you're thinking about a multiple perspective approach. You're thinking about the world around you and all the various perspectives, the perspectives of patients and families and payers and local organizations. It's not just your organization. It's not just one unilateral viewpoint, not just one uniform viewpoint. So many different perspectives exist in a system. In the US healthcare industry as a whole, when we think about big pharma, pharmaceutical companies, when we think about health insurance plans and the Association for Health Insurance Plans known as AHIP, when we think about the needs of individual customers, there's so many perspectives. Even within one entity, let's take a hospital, there are multiple perspectives. There's different leaders, there's different employees, there's different needs within and outside that organization. So it's important to keep that in mind. Now, this is a great video that will help kind of strengthen and increase your understanding of some of those tenets. This is system thinking and complexity in health. So this is something that I think, quickly going through and viewing this would be helpful for your development, but it is only the beginning, right? This is a very succinct view of a very important issue, but again, only the beginning. All right. So when we think about systems thinking in healthcare, realizing that we're an open system, we're interrelated, we have multiple parts that are all working together. We each have our own boundaries, so we're not all one, but we are distinct parts of a larger whole, a larger system. What are the unintended consequences that can happen? And I'll tell you a quick story. Early on, well, actually late on in my health services administration career, there was a law that was released in the state in which I was working that changed the payer provider relationship. It basically was put in place to make sure that individuals without health insurance could not be overcharged. And so the state put a law in place that forbade health systems, hospitals, from charging individuals who did not have a contracted insurance with that hospital anything above their minimum contracted rate. So if you didn't have insurance that, let's say you are from New Mexico and you're getting care in California and you're not covered, your insurance doesn't cover you out of network. Well, California wouldn't bill you at the large cash pay rate or the full charge rate on their charge description master, which is a story for another day. But they wouldn't bill you the total high rate. Instead, they would bill you what their lowest payer pays, which is normally Medicaid, right? Or in California, it's referred to as Medi-Cal, but they would allow you to pay a lower rate, which is really wonderful. But what happened was health insurance companies, such as Blue Cross, caught onto this. And they realized that if they canceled their high dollar contracts with large health systems, they would instead, or could instead argue to be billed a very low rate, bill what the Medicaid rate is. And Medicaid, as we'll talk about later on in the semester, but you may know, is a health plan for low-income individuals who meet certain income criteria across the United States. And so they pay a very low rate. The federal government threw that plan to hospitals. And so health plans, health insurance companies figured out they could take advantage of that. That's not what the law was intended to do. It wasn't intended to save health insurance companies money. And it was that situation was quickly rectified, but it's an example of how anything that we change in our organizations, in the world around us, I call that the policy landscape and the rules and expectations of our society, can have consequences that we don't anticipate. And these happen when you're not thinking about every possible way something can be interpreted, every possible interaction. And that can be taxing, right? But with systems thinking, we try to think about those multiple perspectives and multiple interactions. Now, from a problem-solving perspective, there are a lot of issues with our health system that we can't solve on our own, right? There's been a lot of failed attempts to solve the problem, and it really is just a tricky situation. But that being said, there's a lot that we can do if we avoid blame, if we avoid villainizing certain industries and certain groups, and really go deep into understanding why things are happening and trying to understand all perspectives of the problem. And that's what I'm very hopeful we can do as we chart a new path forward for health insurance in the United States. Now, taking us back to that first question about nurse staffing. Why is retaining nurses a problem? Do they make more money working for specialty hospitals? Is the work difficult? Are they burned out? Are they facing barriers working 12-hour shifts? Is it a career that is largely variable based on setting? And it is. Depending on the state you work in and the setting you work in, the work that you're doing could be very different. And I'll talk about that a little later on in the semester. But we have to think about all the factors that impact those professionals and the work that we do to support those professionals and the work that they're doing caring for patients. And that is not an easy job. So this is just a first little snippet, a little micro lecture. Coming up next is a little bit of an overview of the U.S. health system. And then we'll talk about the history of the U.S. health system. and start to try to dig into some more issues and problems and questions, as well as an overview of the different settings, hospitals and managed care and outpatient. We'll have a great time this summer, or whenever you're listening to this in the future, going through some of these different systems elements.